I really strongly believe I have a smaller hippocampus due to various experiences in my childhood, and I have less neurotrophic effects in adulthood. And that on its own is a cognitive architecture thing that I have to replace. It's sort of like I have to go on TRT. I can't just do a PCT and restart everything. It doesn't work like that for me and my father, for example. So we needed something that's reliable, and that's the case for a lot of my friends as well. I've seen a lot of people's lives being saved by SSRIs. Of course, there's a tremendous risk. Good evening, friends. I want to talk to you guys about a little discussion I've been having on Instagram recently with someone I respect very highly, who's the guerrilla chemist who recently came on my podcast. For some reason, I get tagged a lot in the guerrilla chemist's posts. By the way, I'm unaware of how to remove this. I would like to remove this function. If somebody can comment down below on how I can stop doing this, because then I get reports on responses and so on. Anyway, I'm not a nosy person, and I was not trying to comment on the guerrilla chemist post specifically, but I noticed the discussion about SSRIs that was going on. In the discussion, essentially, and I don't mean to, and hopefully I'll have the guerrilla chemist on again so we could discuss it on the podcast. But I don't mean to summarize inappropriately, but what I understood, and by the way, I didn't even read the original post, so I don't even know what this was regarding. But basically, I got a few points from the guerrilla chemist that bothered me a little bit. One of them was this idea that Big Pharma is out to get us, which I'll talk about in a bit, and that SSRIs are actually a horribly ineffective medication. The guerrilla chemist called them actually one of the most ineffective medications in psychiatry, period, which is the exact opposite of the reality. So I was shocked by this statement, which is factually incorrect, that they increase suicidal ideation and the risk of suicide among people tremendously, and that is overreported, which this subject, the guerrilla chemist has very good reason to think that way, and we'll talk about it in more detail here. But I just want the audience to understand how that works, and that Big Pharma has sort of been hiding from us these amazing molecules that don't have these side effects but do have the benefits, like psilocybin in particular. So I thought I'd prepare some just points that I would talk about with you guys. Everything has already been discussed in great detail in my series on serotonin, but I guess not everyone has the opportunity to watch that series from beginning to end, and not everybody listening or reading these comments has used SSRIs, has used psilocybin, has been depressed, has been anxious, or so on. Personally, I have never been suicidal, so I can't comment on that in particular. Of course, somebody, by the way, responded to one of my posts saying, hey, I took SSRIs, I was suicidal, or maybe he didn't say he was suicidal, but he developed suicidal ideation on the first week or something of SSRIs. So let's discuss how this happens and what's really going on. What's the science behind all of it? So first of all, do SSRIs increase suicidal ideation? I'll describe a couple of things. I've taken some notes here. I'll include some studies along the way, but this is not a literature review. I've only included studies here for you guys to get access to some of the information. So to begin with, there's a recent Swedish study failed to replicate the protective effect of SSRIs on suicidal ideation, but they did note that the duration of SSRI treatment is inversely associated with suicide risk. In a large study on a large European data set, they found that antidepressant-induced suicidal ideation and behavior is rare, just as I described to the guerrilla chemist. It is rare, and that now they found something that is the opposite of the next study that I'm about to discuss with you guys. Number one, they found that combination therapy of multiple drugs showed less suicide risk than monotherapy. Number two, they found that SSRIs increase suicidal ideation risk more than SNRIs, which are reuptake inhibitors of serotonin and norepinephrine, and more than newer drugs. Now, there's a recent study, which I've covered in BioNews. It's a recent meta-analysis of observational studies that concludes that while SSRIs are not associated with suicide risk, all the newer generation antidepressants are, or almost all of them. Most of the newer generation antidepressants are. So that's the first thing. So that's some overview of the studies. There are a lot of studies on SSRIs and increased suicide ideation risk or risk of actually committing suicide. There's a lot of studies. They have mixed reports. The reason is because of study design, study methodology, and meta-analysis. It's also because of the inclusion criteria, their statistical analyses, and so on. You can poke holes through many of the studies, but really what's important is not really to come to a conclusion of whether SSRIs are associated with increased suicidal ideation in a large population, because I think they are. I really think they are. Even if some studies don't show it, I think that they are. But there are reasons they are, and it's important to know those reasons. And once you do understand those reasons, things become a little bit more clear. So let's talk about why SSRIs may increase suicide risk. First of all, SSRIs are not selective, unlike psilocybin. So what is psilocybin? Psilocybin is something like Cabergoline or Pramipexole. Cabergoline and Pramipexole agonize dopamine receptors without using dopamine. Psilocybin skips serotonin and agonizes selective serotonin receptors. They agonize specifically the 5-HT2 class. The 5-HT2A and C class are particularly relevant to the hallucinogenic effects of high-dose psilocybin and LSD as well. And they're also associated with the real reason we microdose them long-term. The real reason isn't because they improve focus and concentration acutely. Psilocybin does do that, by the way. And I believe it does that due to a dopamine transmission or norepinephrine transmission that is consequent to its acute effect potentially at the serotonin receptors. But either way, it has some kind of effect. So it'll improve your concentration acutely, but that's not why we take it. We take it because in the long term, those exact receptors that psilocybin agonizes, the 5-HT2A and C receptors, are the same receptors that the SSRIs rely on to increase the rate of neurogenesis in the brain. What is neurogenesis? The birth of new neurons. There are neurotrophic factors in the brain. We've discussed them a lot in the serotonin series, like brain-derived neurotrophic factor. These things not only grow new neurons, which then causes the brain to become what's called plastic, meaning it's flexible, it can reorganize itself. You can now teach an old dog new tricks, but it also protects other cells from dying. So those are the exact receptors that are used for that. Psilocybin goes directly to them. SSRIs affect other receptors in the serotonin system. Some of those receptors may be responsible for an increase in what's called an anxiogenic effect, an increase in anxiety acutely. You see, the neurogenesis effect with SSRIs doesn't happen until, they say, 3 or 4 months down the line in the studies. But for me personally, and for most of my clients, it took 6 to 7 months. So for the first few months, you're not getting that neurogenesis. With psilocybin, it's more direct to the 5-HT2A and C receptors. Potentially, you could get neurogenesis faster. There are no studies comparing this yet, to my knowledge, but I can see how that could happen. The point here is that SSRIs are less specific, and psilocybin replaces the effect of serotonin. It goes directly to one place. Okay, so that's one difference. Secondly, SSRIs inhibit dopaminergic function. They do this acutely and chronically. Within the first week, you'll have a reduction in your ability to feel dopamine in the brain. This reduces addictive behavior, but could potentially cause somebody to feel anhedonia. They could start the SSRI, feel anhedonia, have no neurogenesis, they're not going to have it for another 6 months, and feel like crap. Totally makes sense. Now, I don't know if psilocybin does the same thing. I really doubt that it does, through my personal experience, extensive use with psilocybin, and just generally, it doesn't seem to inhibit dopaminergic function, but it might. It's unlikely that it does, because at least acutely, because not only does it feel like it causes dopamine transmission, but if it inhibited dopaminergic activity, it would be hard for psilocybin to cause schizophrenia and bipolar disorder in single doses, heroes doses of the drug, because dopamine is very much involved in schizophrenia and bipolar disorder. So if it was inhibiting that, it's very, very unlikely to cause those things. Yeah, that's one of the dangers of taking heroes doses, by the way, but we'll get into that later. Yeah, as I mentioned, SSRIs do not work for 6 to 7 months. So the first 6 to 7 months, the effect of the SSRI, the beneficial effect, is not there. So if you see an increase in suicidal risk, it could be because, for example, they're expecting an effect. They don't get it, lose hope. It could be because of that dopamine blocking effect. It could be other things. The next point I want to mention is SSRIs' side effects occur within a week usually. The side effects occur when you ramp up the dose and when you start it. Those are the 2 times you see the most side effects psychologically and physically. So the most side effects will be seen in the first week. Most of the studies are 1 to 4 weeks long, the ones that study the suicidal risk. So you've not really seen the benefits yet, but you've seen most of the side effects. This is one reason, by the way, that I recommend people always to start with microdoses of SSRIs at night. Doses that are so low that they don't even inhibit SERT. And only to raise the dose when you see absolutely no effects. You don't even notice lethargy or dopaminergic inhibition. You don't notice anything. That's when you raise it, to be careful. I also wanted to mention that SSRIs are prescribed to people who are depressed and more likely to commit suicide in the first place. Of course, if you give this to somebody that is not depressed, it's much less likely. We have to keep that in mind, right? Finally, there are people that are called there's something called treatment-resistant depression, which is the reason why ketamine and various other drugs are being developed for the treatment of, and psilocybin-related analogs are being developed for the treatment of depression. Treatment-resistant depression can come from a lot of things. I think we'll talk about these a little bit later in this talk. By the way, this talk is a little long-winded. I'm sorry, guys. I wasn't planning to give a talk on this subject. I want you guys to keep in mind, before we go to the next point, I'm not paid by Big Pharma. I don't benefit from SSRIs, and I don't have a supplement company. So I don't have a horse in the race, let's put it that way. I've used both. I've been depressed and anxious. My family members have, my friends have. I've seen effects over the long term. Unfortunately, guerrilla chemists, who I respect highly, dismissed some of my personal experiences, saying that these are subjective and maybe placebo and so on. Unfortunately, I've used the SSRIs many times, on and off, waited months back and forth, tried them with different drugs, had so many people with me try them, and read so many studies on them, and understand the actual mechanisms behind how they work. So I am quite certain that SSRIs work. In fact, you guys can see it yourself, noticing how much more hostile I've become in the last 4 or 5 months since I stopped using SSRIs about 8 or I guess a long time ago, in order to get my wife pregnant and try not to have my genes reflect the fact that I was taking SSRIs. So that change in behavior you can see that is actually mainly the SSRIs that I've taken out of my... So you can see there's certainly effects of SSRIs. It's not imaginary, okay? I'm certain of that. But anyway, also now, why do SSRIs work on some people but not others? Let's talk about this. We talked about this in the Serotonin series, but we're going to review it. First of all, there are metabolism polymorphisms. That means that certain SSRIs, so you have polymorphism in your cytochrome P450 enzymes. They start with CYP and have a number. Different SSRIs are metabolized by different CYP enzymes. You may be taking an SSRI that you metabolize very slowly, in which case you'll see enhanced side effects that first week, suicidal ideation and so on. Or you metabolize very quickly, in which case you get much less than the effective dose that you're trying to get. Number 2, you may have polymorphisms in the promoter region of your serotonin transporter SERT. If you have certain polymorphisms there, SSRIs are never going to work that well for you anyway. And psilocybin will always work better for you. Why? Psilocybin doesn't use the SERT transporter. Now, if you don't want to check out your genes, then you won't know this. But if you put the effort in, you'll figure this out pretty quickly. So there's no reason to demonize the SSRIs, because some people, a small portion of the population, have promoter regions of the serotonin transporter that don't really get an effect from the inhibition of the SERT transporter. They need something like Cabergoline. They're sort of like Parkinson's people that don't have dopamine and need Cabergoline to agonize that dopamine 1 and dopamine 2 receptors. So, next, 3, polymorphisms in the serotonin receptors. So SSRIs don't just involve the 5-HT2A and C receptors, and polymorphisms there affect how it'll work too, by the way, but they'll also affect how psilocybin would end up affecting you, because it works through neurogenesis in the long term, chronically. But there are also polymorphisms, for example, in the 5-HT1A receptor. That's an autoreceptor. You remember it from my series. Polymorphisms there heavily affect how you react to SSRIs. So it's individual serotonin receptors. And finally, polymorphisms in the actually important, relevant long-term effects. For example, polymorphisms in the brain-derived neurotrophic factor gene. If you have a brain-derived neurotrophic factor that is underactive naturally, you will have a differential effect from SSRI treatment than somebody else does 6 to 7 months down the line. Again, not in the beginning. Now, let's get into other drugs. Do other drugs not enhance suicide risk? Let's talk about ketamine. So there is some evidence that ketamine may not or may reduce suicidal ideation acutely. Why is this? Now, I'm just thinking about it, by the way. This is not evidence from academics. This is me postulating. Number 1, ketamine is an NMDA receptor antagonist, meaning it lowers the excitatory to inhibitory ratio in the nervous system. Reducing that excitatory to inhibitory ratio, in my experience, reduces anxiety acutely and chronically, reduces inflammation chronically, and that's known in the literature, which of course affects anxiety and so on, but also in my experience reduces impulsiveness a little bit, which is really important. Now that's just personal experience, okay? Now ketamine is a mu opioid receptor agonist, something that people often fail to mention or to know even. which is something I mentioned to the gorilla chemist on our last discussion. By the way, the gorilla chemist was not talking about ketamine. I'm just mentioning this for you guys. Now, the interesting thing is that ketamine's effect on anxiety and depression requires, although it doesn't seem to be initiated by the mu opioid receptor, that is the target of morphine and heroin and so on, but it seems to depend on, in the sense that if you block the mu opioid receptor, MOR, if you block it with naltrexone, the effects of ketamine on depression disappear. So that's one interesting thing. So what's ketamine really doing before we move on to psilocybin? Ketamine is causing a dopamine transmission downstream to the mu opioid receptor modulation. That happens with any mu opioid receptor modulator. It causes dopamine transmission. They cause downstream serotonin transmission, which is relaxing usually in that context. And of course, this thing again lowers the excitatory to inhibitory ratio. So it's sort of something like, of course, it wouldn't increase suicidal risk. I wouldn't think it would, personally. So that makes sense. But is that a good long-term target to deal with this kind of problem? I don't know. Personally, I would think that messing with the mu opioid receptor long-term and having such a potent antagonist of the NMDA receptor would be, the second one would be neurotoxic. And the first one I would feel would be dangerous, but who knows? We haven't experimented that much. Ketamine is being used to target this thing called treatment-resistant depression. Now, psilocybin, within 4 weeks, it is an effective antidepressant. And maybe it's causing neurogenesis quicker. Maybe it's causing that dopamine transmission in the short term, which wouldn't decrease that much in the first month. Now remember, for example, for comparison, in the GABAergic system, benzodiazepines reduce cortisol for the first month. They do it for the second month too. It's the third month that cortisol begins to climb up, tachyphylaxis occurs, and the inhibitory to excitatory ratio readjusts. So who knows if psilocybin would be an effective antidepressant in 2-year-long treatments and things like that. We don't have that yet. We don't have any dedicated study on psilocybin and suicide risk, and probably because, honestly, it's probably impossible to study that in humans because of ethical reasons. So that's about psilocybin. Now, what about psychedelics? Are they not associated with increased suicide risk? Now, number one, lifetime use of psychedelics, like just the fact that people use psychedelics, that is associated with less suicide risk in general. But this is probably associated with many other proxy variables. It's probably a proxy variable that's taking account of many other variables, such as openness, which is a characteristic of personality, openness to new experiences, probably taking account of the effects of subjective experiences with psychedelics, which are different than long-term treatment. So subjective experience is this: you go on a DMT trip, you go on a psilocybin trip, a hero's dose of 4 grams of golden teacher mushrooms, or you go on whatever, you take a high dose of one of these drugs. What happens is you get a subjective experience. This subjective experience that you're feeling that day alters your perception somewhat permanently, or for a long time, of life, making you more open to new experiences and so on in the long term. That really may reduce suicide risk potentially also. In fact, there's a study here that shows that post-psychedelic reductions in experience avoidance are associated with decreases in suicidality. So now, which drug is best for suicide prevention? I don't know. I'm not a psychiatrist, and I certainly have never had suicidal thoughts myself. However, I'll tell you something. The research that I've seen in general, and I've never studied suicide, and my experience with psychiatrists personally, points me to the obvious observation that high-dose lithium treatment is the treatment that is most associated with improvements in suicidality, especially among people with bipolar disorder, but I believe potentially in general. Why? Lithium works via upregulating serotonergic activity, somewhat similar to an SSRI, but it also is a potent mood stabilizer, sort of like sodium valproate or other bipolar medications. The combination of the two, I think, is a really ideal approach to suicide. But I don't know. I've never treated, obviously, I've never had this myself. But the research is consistently reporting lithium as the anti-suicidal drug, not psilocybin. So I'm not sure where that's coming from, this idea that psilocybin is particularly anti-suicide, but who knows? Lithium certainly is the one that's been used in long-term studies. By the way, for people to know, just so you know, lithium is extremely, at the doses needed, which are around 800 to 1,200 milligrams a day, at those, or 600 to 1,200, let's say, at those doses, lithium is potently renotoxic. It can really destroy a person's kidney function over a period of 20 to 30 years. But in the short term, in a year or two, it's really an effective treatment, and probably a better treatment than SSRIs for people that have depression and suicidal thoughts. Of course, you should consult your doctor and ask and try to look at the research yourself. Anyway, now let's get into the subject, because Guerrilla Chemist also mentioned that psychiatry, its worst or its least effective medication that it introduced were SSRIs, which I found really bizarre. So, number one, what is psychiatry? Psychiatry is the treatment of mental disease with medication by doctors. In the history of psychiatry, there have been two major groups of medications that have been very successful for the treatment of mental illnesses. One group are called tranquilizers or antipsychotics, later antipsychotics. These medications are very useful for the treatment of schizophrenia and bipolar disorder. The other group are what are colloquially called antidepressants, also called that in the academic literature actually. Antidepressants include originally the tricyclic antidepressants, the monoamine oxidase inhibitors, SSRIs, which are selective reuptake inhibitors to serotonin, SNRIs, dopamine and norepinephrine reuptake inhibitors, and now other drugs like ketamine and so on. Of these classes of drugs, the drugs that have had the most impact on depression and anxiety in the history of psychiatry are SSRIs. They are considered the number one, the best drug for the treatment of depression in general. They're the first line course of treatment. They definitely work. There are hundreds of thousands of people around the world who have taken SSRIs for 20 years straight and had major benefits from them and so on. In psychiatry, to be honest with you, SSRIs are almost, other than the tranquilizers and antipsychotics, they're almost the only very effective medications that have been introduced. As I said before, very effective depending on genetic polymorphisms, depending on the SSRI of choice, and depending on long-term use. This is not to say psilocybin is not effective, but it is to say that in the history of psychiatric medications, SSRIs are considered by psychiatrists to be among the top 2 or 3 most successful medications in their history. And why do people stop SSRI treatment, by the way? The main reason is actually sexual dysfunction. That is the main reason that people cease the treatment of SSRIs, including, many people, including myself, the first time I used SSRIs, that's the reason I discontinued treatment. And I did so 4 months into the treatment, before I experienced any of the benefits. I went years thinking that SSRIs didn't work, by the way. I've been in that position before. I've also, I've been there. Another thing I want to mention is most people stop SSRI treatment before they reach that 6-month mark. So most people who have used SSRIs have never actually experienced that feeling of very enhanced neurogenesis that I happen to notice 6 to 7 months or 7 to 8 months into SSRI treatment. And most of my consultation clients who have decided to use SSRIs, I started taking consultations a year and 2 or 3 months ago. Most of them who have used SSRIs since then have had the same experience as me. 6 to 8 months down the line, a sudden message, wow, this is life-changing. So we've been through this now. Why is Big Pharma to blame for all of this? Well, first of all, Big Pharma must select patentable drugs. So if they cannot patent a drug, they do not want to encourage its use. They want to make money off it. Second of all, Big Pharma does not want to fix you. Just like doctors, sort of, their incentives are for you to take a medication for the rest of your life. So if you could be fixed with one subjective experience from LSD or psilocybin or DMT or ketamine and never need SSRIs again, Big Pharma, their incentives will be against you. They won't want you to do that. That's true. Of course, that just makes sense. This comes from economics. I have an undergrad degree in the field related to behavioral economics, microeconomics. And in microeconomics, we always look for what? We don't look for what people say, we look for their incentives. So absolutely true. I agree with Guerrilla Chemist. There's a lot of dangers with the incentives that Big Pharma has. Big Pharma has a lot of hurdles also for the drugs that it can introduce for prospective drug studies. Now, in general, these hurdles aren't necessarily incentivized against us, for example, but sometimes they are, and not to the aid of Big Pharma either. So, for example, in cardiovascular medication research, it's almost impossible, maybe until recently, maybe we'll see a change now, but historically it's been almost impossible to give prospective drug trial patients no statin, people who are, for example, when you have to, if you want to introduce a new drug for cardiovascular disease, you have to use people in your study who have cardiovascular disease. Because if you don't, this, first of all, your study can only be funded for about 4 years. Now, cardiovascular disease is a lifetime disease. So if you catch somebody at the age of 40 in your cohort who has no plaque and no cardiovascular disease, you're probably not going to see any effects for the 4 years that you're studying. You might see effects 30 years down the line, but you can't fund that. So you have to take the people who have already had heart attacks, who've already had all these other things. Now, when you take these people in, if you don't give them in the control trial, if you don't give them a statin, you are doing something slightly unethical, because they may die because you didn't give them a statin. So now you have to give both the control and the other group a statin and add another medication onto that. And if the other medication shows a difference in heart attacks in 4 years, which again is a very short time period, then potentially you could get that drug approved. So for example, this recently happened in the REDUCE-IT study with Omegavia, prescription ethyl ester EPA, which in that study, which was 4 or 5 years long, of people with cardiovascular disease with statins, it was still shown to decrease mortality, or cardiovascular mortality, maybe specifically, I don't remember, by around 25% in that time period. So it's difficult to do that. Are these incentives necessarily against, like some kind of conspiracy against us? I don't think so. Sorry for being long-winded, guys. I want to be comprehensive. Now, next, SSRIs versus psilocybin. Number one, why don't I recommend psilocybin? Am I against psilocybin and psychedelics, or do I not have experience with them? No, it's not that. In fact, some consultation clients that I have mention their fear of sexual dysfunction, and sometimes we consider using psilocybin so that we can skip potentially the other receptors that may be involved in the sexual dysfunction that comes from SSRIs. We may use, for example, a beta blocker also to reduce that sexual dysfunction further by blocking the 5-HT1A receptor. And we may use psilocybin directly to agonize that 5-HT2A and C receptors. But we'll probably be using something else, which I'll discuss in a second, which is more potent than psilocybin at this effect. But I'm not against it. I've used all kinds of mushroom strains. I've used azurens, I've used cubanense. I don't even know how to pronounce these things. I have tons of strains. I use all kinds of psilocybin. I'm not against it at all. I don't think that my psychedelics are bad or anything like that. The real reason is because, mainly like, okay, if someone can tolerate an SSRI, I don't want that acute effect of the psilocybin mushrooms to be messing with potential other neurotransmitter systems with me not knowing exactly what it does. So when I take a psilocybin mushroom, I find enhanced energy, enhanced concentration, and so on. For example, at the 200 to 300 milligram dose if you're using a golden teacher mushroom. I don't want downregulation in those receptors long term if the person's not against using something that like an SSRI under the care of their doctor. Sorry for being so long-winded, guys. The next subject I want to discuss is SSRIs versus psilocybin. Am I against the use of psilocybin in general? Absolutely not. I've used psilocybin extensively in my life. I think it's very useful in some contexts, especially when people are averse to the side effects of SSRIs, have a kind of depression that involves a lack of energy, and in many other contexts as well. Why I don't recommend it as a go-to, first of all, is because SSRIs are, we'll talk about that later. Instead of SSRIs, what do I usually like? If someone can't use an SSRI, is psilocybin my first go-to thing? Not then either. So recently, as you guys know, I've been experimenting with mega doses of cerebral lysine, which is porcine neurotrophic factors. But even before that, I was using microdoses, 1 milliliter 3 times a week, every other day, or 1 milliliter at night, and so on. I've seen much greater effects of using this than psilocybin at reducing anxiety, at reducing depressant symptoms, and so on, because it creates an acute neurogenic effect. So it sort of skips those first 6 months. In fact, nowadays, when people go on SSRIs that I know, I often recommend to them, under the care of their doctor, to consider using cerebral lysine for the first 6 months. You could also use psilocybin on top of that for other reasons. It's just not a go-to mainstay of my program because, let's discuss this. Think of it this way. Why do I like the SSRIs? Number one, they're tried and tested. The safety profile is excellent. We have 30-year studies of people using SSRIs. We have people that have been using SSRIs continuously for long periods of time. We know how they may affect the heart. We know how they may affect the cardiovascular system, the endothelial structure. We know potentially the side effects of SSRIs. I love this side effect profile and this, safety profile. I don't know the same about psilocybin, so that's one of the reasons that draws me away for it. Why I like SSRIs, even for people who are not undepressed or anxious, includes, for example, the two mainstays of why they work. This increase in neurogenesis that occurs after 6 months, down the line, and this reduction in neuroinflammation that comes with SSRIs. These two things are, for example, I believe, protective for future development of neurodegenerative disease. One of the hallmarks of neurodegenerative disease is an increase in inflammation in the nervous system, a decrease in neurotrophic factor expression, and an increase in apoptosis of the cells in the nervous system called neurons. So in this way, the use of SSRIs in the long term, in my perspective, is sort of protective, or I believe, at least for me, it will be protective for neurodegenerative disease. I also believe that they are performance enhancing for people that do not have mental disorders. In fact, this has been hypothesized from 15 or 20 years ago, or more than that, maybe even 30 years ago, people started thinking that. It hasn't been explored that much. I can tell you from my personal experience, having not been depressed or anxious the last time I began SSRI use, that in my experience, it's very performance enhancing. It allows my brain to be agile. Because of the growth factors that are in my brain continuously, I find it's much more difficult to ruminate on things that bother me. It's easier for my brain to adapt new practices, for my system to habituate itself to new patterns in my lifestyle, to be more accepting of new ideas, to have sort of a flexible soul, really. So this is why I sort of like SSRIs. I don't really have anything against psilocybin. It's just less studied and so on. I hope you guys understand this. And in general, my perspective is really to focus on mechanisms. So the mechanisms behind SSRIs are specifically that 5-HT2A and C receptors that psilocybin works through too. So when we're comparing SSRIs and psilocybin, we're not really comparing, we're really talking about that same pathway there. I'm just talking about a drug that's more studied and that I don't demonize. I'm not demonizing psilocybin or saying it's necessarily very bad. I'm very concerned, and that's about demonizing SSRIs. And this is the reason I made this video, because there are people like myself, my father, for example, honestly, like my father stopped SSRIs. I remember when I was 10 years old. It was the only time in my life that I'd seen my father become, a nicer person. He wasn't hostile toward me. He wasn't, whatever. I don't want to get into details, but he became sort of a nice person for about 8 months of my life when I was around 10 years old, and he stopped. Years later, I asked him what was going on there, and I found out that he took fluoxetine, Prozac, and he stopped 8 months down the line. Why? Because of the sexual side effects. And he went back to who he was, and he went back to what he was doing, and so on. So for me, it really affected my life when my father decided to choose his, basically choose sexual function over repairing his cognitive system. See, my father and me aren't the type of people that can have a subjective experience. Like, we can't do heroes doses of psilocybin and just be good after that. Because it's not so much just the perspective that's an issue with us, it's our actual cognitive architectures. So for example, in my case, I really strongly believe I have a smaller hippocampus due to various experiences in my childhood, and I have less neurotrophic effects in adulthood. And that on its own is a cognitive architecture thing that I have to replace. It's sort of like I have to go on TRT. I can't just do a PCT and restart everything. It doesn't work like that for me and my father, for example. So we needed something that's reliable. And that's the case for a lot of my friends as well. I've seen a lot of people's lives being saved by SSRIs. Of course, there's a tremendous risk. If you are a suicidal person, anything you do that first week may ruin you. And you definitely need a doctor who will tell you that this drug will not work for 6 months. And not only that, we have to use the right drug, and we have to use a very low dose and be very careful about raising it, so we don't get this negative feedback that could potentially be anxiogenic and so on. But to demonize the whole SSRI category is really risky, because you may be preventing people like myself and my father from finding solutions that work in their life, right? So that's my point here, and that's all. I hope guerrilla chemists will understand where I'm coming from, and this is not, an issue about being anti-supplements or pro-drugs or anything like that. It's just about this class of drugs works for certain people. It's not a freaking placebo effect, that's for sure. You can even see that in the research. There's an enhanced neurogenesis. There's a neurogenic hypothesis of depression. There's an inflammatory hypothesis of depression. It reduces inflammation in the nervous system. All of these things are known for sure, and I feel them. When I take Cerebral Lysine at a dose of 5 milliliters a night for 5 days in a row and stop, the feeling on the 6th day is like being on an SSRI at the max dose for 1 year. It's the exact same feeling. Honestly, I've been there, done it multiple times. I encourage, if people are you know, want to find out for themselves, they can. Anyway, guys, thank you so much for bearing with me. I'll see you next time.